Kia ora koutou katoa. My name is Ella Ewan, and I'm here today representing the WHO organisation from Western Pacific region. And today I'm going to talk to you about the childhood obesity and why it should be included on the 74th World Health Assembly. In the last 7 decades, there has been huge progress on global health, with child mortality reducing, life expectancy increasing, and the almost elimination of polio. But today, non-communicable diseases account for 70% of all death globally. Childhood obesity is an urgent and serious public health challenge affecting every country in the world. Childhood obesity is defined as a BMI more than 2 standard deviations from the WHO growth reference, and overweight being 1 standard deviation from that reference. Childhood obesity is preventable, and in 2016, it's estimated 41 million children under the age of 5 are overweight or obese, and that's 340 million between the ages of 5 and 19. That represents about 1 in 5 children globally. And childhood obesity may negate the progress and the health benefits of increased life expectancy. An additional 124 million children and adolescents were obese in 2016, which represents a 10-fold increase in the last 40 years. 2/3 of these are in low and middle income countries. And what are the costs? Well, 2 trillion per year is estimated to be linked to global obesity costs. And morbidity, 2.6 million deaths are attributed to obesity. But there are, of course, further deaths from heart disease, stroke, of which obesity is a major risk factor. So what are the trends over time? Well, infant, childhood, and adolescent obesity is increasing in all WHO regions of the world. The share of children and adolescents aged 5 to 19 who are overweight or obese has risen from 4% to 18% between 1975 and 2016. More recently, between 2005 and 2017, the global overweight children has gone from 32 to 38 million. The prevalence of child and adolescent obesity is expected to surpass that of moderate and severe underweight by 2022. Overweight is increasing rapidly in low and middle income countries, particularly in urban settings and areas such as Northern and Southern Africa, the Middle East, Asia, and the Pacific Islands. In Africa, the number of children, for instance, under 5 who are overweight has increased by nearly 24% since the year 2000. There is some good news, however. Rates have been plateauing in countries, high-income countries such as Sweden, Switzerland, France, and Australia. And the flatter graph seems more marked for girls and boys and is declining more in preschool-age children. Extreme obesity, however, is increasing. So if we take a look at the prevalence of childhood obesity between ages 5 and 9, with the highest rates here seen in the dark colour, over 25%, and the lowest rates in the lighter colour. We can see high rates in Alaska, America, Argentina, and North and South Africa. And if we look at an older age group, 10 to 19, we can see still high rates in America and in Northern and lower Southern Africa. However, overall, the map does look a lighter green in colour. If we turn now just to focus on the Western Pacific, there is great variation in rates of obesity and overweight amongst the 37 countries which make up this region, with the lowest rates in Cambodia, and we can see the highest rates in Pacific Islands, with Cook Islands taking the win. In the Western Pacific region, childhood obesity is a major public health challenge. There is a great variance, though, across these countries. We'll keep in mind that China makes up 70% of the population, and there are many countries that have much lower populations, such as Niue, with 1,000 people. There are health system variances between these countries, with some very strong, some very poor, and in some areas the populations are exploding, whereas others, they are rapidly aging. Prevalence, though, of childhood obesity in the region is climbing, particularly in East and South Asia. The highest prevalence of obesity is seen in age 5 to 9 amongst the Pacific Island countries. The prevalence for adult obesity varies greatly. You can see very low rates in Japan, with very high rates in Samoa, New Zealand somewhere in the middle. And for the Western Pacific region, the double burden is a big issue, increasing overweight and obesity, but also while they're trying to battle undernutrition and stunting. So who is affected? Well, younger children are affected, as well as school age and adolescents. In low and middle income countries, as I said, the double and sometimes triple burden of malnutrition is affecting these countries. In absolute numbers, there are more children obese and overweight in low and middle income countries compared with high income countries. 75% of overweight and obese children live in Asia and Africa in the under 5 category. Looking at gender, 18% of girls and 19% of boys were overweight in 2016, and 24% of boys in high income countries compared to 23, so slightly higher in boys. In low and middle income countries, it's more balanced across the sexes. So what are the health consequences of childhood obesity? Well, it affects almost every organ in the body, short-term, long-term, physical and mental health consequences. Weight loss and treatment is very difficult to maintain and achieve, and childhood obesity increases the likelihood of lifelong obesity and also the risk of premature onset of non-communicable diseases such as heart disease, stroke, and diabetes. There are a whole host of other conditions here, such as cancers, and of course we're learning more about the psychiatric, psychological, and psychosocial effects of childhood obesity, such as low self-esteem, emotional and behavioural disorders. On average, children with childhood obesity have a lower educational attainment and lower quality of life. There are social and economic consequences of childhood obesity. So if we look here at the leading causes of death globally in 2019, we can see that many of them have obesity as a risk factor, and they attribute many of the global deaths. So what are the determinants of childhood obesity? Well, in its simplest form, obesity is an imbalance of calories in and calories out caused by unhealthy diet and insufficient physical activity. But obesity is a normal response to an abnormal environment. In 1999, Professor Boyd Swinburne and colleagues described the obesogenic environment as a sum of opportunities and conditions of life that promote obesity in an individual population. In particular, the availability, affordability, and marketing of calorie-dense and nutrient-poor food, and the decline in physical activity, increases in screen use and sedentary activities. Overweight and obesity does seem to be more prevalent in urban rather than rural settings, and in low and middle income countries, it's higher prevalence in low income households. There are large inequities for childhood obesity across ethnic groups and geographic areas. Children are very susceptible to food marketing, and so reducing child's exposure to obesogenic foods and their marketing is necessary to protect them. Now, much work has been done by the WHO, including these reports, for example, and strategies and commissions. From the left, we have the Commission on Ending Childhood Obesity, 2014, the Global Action Plan on Physical Activity. We've got the Taking Action on Childhood Obesity Report, 2018, and the Global Strategy for Diet and Exercise from 2004. And also the United Nations Decade of Action on Nutrition, 2016, and of course the UN Sustainable Development Goals, of which many of these goals are related to childhood obesity, such as Sustainable Development Goal 2, which is about healthy and sustainable food system and ending hunger, Sustainable Development Goal 3, prevention and control of non-communicable diseases, and universal health coverage. If we turn now just to focus on the Ending Childhood Obesity Commission, which was established in 2014, 15 individuals from a variety of different backgrounds made up this group. And there was a science and evidence group as well as an implementation monitoring group. The goal was to no increase in overweight in children under 5, school-age children and adolescents by 2025 from the 2010 levels, and also to reduce the mortality and morbidity of non-communicable diseases, and also raise awareness and build momentum for action on childhood obesity, address gaps in mandates and strategies on childhood obesity, and provide policy recommendations to prevent children developing and also treat obesity, lessen the negative psychosocial effects. So from this commission, they produced a report and it had recommendations for policymakers in 4 areas: leadership, so taking ownership, engaging politicians; joint action, coordinating sectors; data for action, which was monitoring things like BMI; and good governance, which is like developing guidelines. They made 6 key areas of action, which was number 1, promoting intake of healthy foods, programs that increase the uptake, things like sugar taxes, recommendations and regulations. Number 2 was promoting physical activity, enabling environments to promote physical activity. Number 3, preconception and pregnancy care. Number 4, early childhood diet and physical activity, including supporting mothers to breastfeed. Number 5, health, nutrition and physical activity for school-age children. So this includes standardizing standards for meals in schools, nutrition literacy, etc. And number 6, weight management. All countries agreed to global targets for halting the increase in obesity. The report was very comprehensive, but it did exclude or need more focus in some areas, such as reducing inequities. As we know, childhood obesity rates are much higher in those living in areas of deprivation. Improving urban planning, so to encourage physical activity such as active transport, walking to school, etc. And reducing food insecurity, more focus could have been given here, as we know it's linked to the consumption of unhealthy food. And also improving nutritional quality of food, working with industry to reformulate the reduced sugar and salt, for instance, or reducing portion sizes. There have been a number of wins, though. In the last decade, there's been a lot of progress. More than 45 countries have introduced a sugar tax, which has driven down intake of sugary drinks and also driven reformulation from industry. There has been campaigns on reducing and policies on reducing junk food advertising, such as in Chile. In the UK, there was a Veg Power campaign to increase vegetable intake for children, which resulted in 89 million more vegetable serves sold and consumed. And there has been physical activity campaigns such as the 60 a day Move Your Way by the CDC in the US, and in Finland, the Schools on the Move campaign, which was taken up by 62% of schools. In Australia, the Learn Your Fruit and Veg program from Jamie Oliver to improve the food environment in schools. And then also in France, they banned vending machines at schools. In the Pacific, there is new healthy living guidelines from 2018 for professionals and educators. And there's been a lot of examples of front of pack labeling, such as these black and white warning packs labels in Chile. And to increase breastfeeding in the West Africa, there was a support breastfeeding campaign. And in New Zealand, increased baby-friendly accreditations of maternity facilities, increased breastfeeding from 56 to 83%. So what are the actions for the World Health Assembly? Well, progress on tackling childhood obesity has been slow and inconsistent. There has been patchy implementation of the WHO strategies and political inertia seen. We are still off track in many countries to reach the 2025 target, and bolder action is urgently needed. The WHO should drive more awareness on the severity and the consequences of childhood obesity, as it's lacking, particularly in countries where undernutrition is common. They should provide excellent leadership and amplify the mandate of on areas such as NCDs, non-communicable diseases, diet, physical activity, and health. They should reinvigorate and build on the momentum made from the Commission on Ending Childhood Obesity and also the Global Strategy on Diet, Physical Activity, and Health, which act on behalf of the child to reduce the risk of obesity. And they should institutionalize a cross-sector and life course approach to ending childhood obesity by continuing to drive government leadership and accountability of all stakeholders. This could include things such as stronger, more specific global recommendations from the WHO on marketing to children, for instance, no marketing to children under 14, building more cooperation between member states to reduce the impact of cross-border marketing of unhealthy foods, standardized global nutrient labeling systems and stronger guidelines for meals in schools, and continuing the great work on driving preconception antenatal care and promoting breastfeeding benefits. They should also provide WHO guidelines on sleep, sedentary time, physical activity, and active play. And as I mentioned, a greater emphasis on reducing inequities to the social determinants of health. In conclusion, childhood obesity should be included at the World Health Assembly on the agenda, as it is a global emergency, one of the most important global health concerns of our time. Childhood obesity affects physical, social, and psychological well-being, and it can lead to lifelong obesity and non-communicable diseases. Addressing child health with bold actions and long-term investment will help meet the global health targets and substantially reduce future health and economic costs of childhood obesity. Thank you.